Well lads, what's going on? I'm Rory, and we're doing our project on alpha-1 antitrypsin, which is Owen Durkin's research. Now, thanks Helen for throwing us under the bus with this one, because we really haven't a clue what's going on. So we're going to go have a look ourselves, do a bit of research and see what's going on. So, see you after a bit, alright? Well, story horse, how are you getting on? So I did a bit more research on alpha-1 antitrypsin, and basically, to make it easy for you to understand, I'm going to break it into three parts. So physiology, genetics, and treatment. Now I'm going to try and make it as fun as possible, but it's really that fun listening to physiology, so I'll try my best, alright? When you get sick, in your body these cells go to the site of infection, and these are called neutrophils. These neutrophils try to break down the bacteria by releasing a protease called neutrophil elastase. Now this neutrophil elastase is good that it breaks down the bacteria, tries to reduce the inflammatory, but it also breaks down the elastin in the lungs. Now breaking down the elastin in the lungs is not good, and this is where alpha-1 antitrypsin comes in, alright? Right lads, so elastin is a really important extracellular matrix protein for the lungs. Now elastin provides strength and elasticity for your lungs. And basically with your lungs, obviously, contracts and expands. So you need your lungs, you need elasticity and strength. Without this elastin, this won't be able to happen. This is where alpha-1 antitrypsin comes in. So alpha-1 antitrypsin is a protease inhibitor. It's made in the liver, released into the bloodstream and makes its way to the lungs. Now when it makes its way to the lungs, it stops the elastin from broken down by inhibiting the protease neutrophil elastase. So basically, when it gets to the lungs, it stops the elastin from broken down. That's all you really need to know.
Well lads, what's going on? So you're probably noticing that I'm a little bit overdressed to be teaching you about genetics, but yeah, so it's the student races today and I'm actually here in Nathan's in Snowden, and basically due to our absolutely mental assignment deadline schedule, I have to film this before we go out, so let's get this done fairly quick and then we can go watch some ponies. So right, the genetics for alpha-1 antitrypsin. So the gene that codes for alpha-1 antitrypsin is the SERPINA1 gene, and it's found on the long arm of chromosome 14. So the regular variant of this gene that most people have 2 copies of, each copy you have produces 50% of normal levels of alpha-1 antitrypsin. But there's another variant called the PIZ gene, PIZ variant of the alpha-1 antitrypsin producing SERPINA1 gene, and this version produces misshapen, misfolded alpha-1 antitrypsin, and this can actually lead to the misshapen proteins getting caught in the liver, and this can lead to breakdown of hepatocytes, liver cirrhosis, liver failure. And so if you have one copy of this PIZ gene, or variant of the gene, then and another healthy copy of the gene, then you'll have about 60% of your alpha-1 antitrypsin levels. But if you have two copies of the PIZ variant, then you'll only have 15 to 20%. So 60% of your regular alpha-1 antitrypsin levels is usually enough in non-smokers, but if you have 15 to 20%, then that's actually what's termed alpha-1 antitrypsin deficiency. So another interesting variant of the SERPINA1 gene is when it codes for absolutely no alpha-1 antitrypsin production at all. And this is strange when you compare it to the PIZ variant, because you have none of the liver complications that you do with the PIZ, because there's no alpha-1 antitrypsin getting stuck there. But you also have less protection from the from external factors in your lungs, like to combat the neutrophil elastase breaking down the elastin. So there are actually people who have no alpha-1 antitrypsin at all, but they just live in such healthy, clean external environments that they end up having no symptoms of it at all. So yeah, that's an overview of the genetics, and yeah, so now we're going to go and place a few bets on some ponies.
Well, you've had fun at the races anyway. Cheers for the physiology and genetics lectures, Cian and Rory. You might take after Rory's Lamiette. Today I'm going to go through the treatments for alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency can lead to the development of some COPDs. These include emphysema, bronchitis and bronchiectasis. A lot of the signs and symptoms of alpha-1 antitrypsin are the same as these COPDs, and asthma as well. For this reason, although alpha-1 antitrypsin is not a rare disease, it is often rarely diagnosed. Now, you might be wondering what signs and symptoms can be seen in the liver. Well, as Cian has already discussed, alpha-1 antitrypsin deficiency can lead to cirrhosis of the liver, but it can also lead to detoxification problems and even potential development of a liver cancer called hepatocellular carcinoma. Even newborn babies born with alpha-1 antitrypsin deficiency who have two copies of the PIZ mutation can even have some complications such as jaundice or even liver failure. So, how can we tell if these signs and symptoms are due to alpha-1 antitrypsin deficiency? Typically, diagnosis starts with chest x-rays and CT scans to check for damaged lung tissue. Additionally, pulmonary function testing, such as the ones that we did in the lab practical, as well as blood tests can be done to diagnose alpha-1 antitrypsin deficiency. If the individual has developed cirrhosis of the liver, liver ultrasound can be done, as well as liver biopsy. So finally, the treatment of the condition. Augmentation therapy can be done, which involves the intravenous infusion of normal alpha-1 antitrypsin. This doesn't cure the disease, but it does help to limit the negative effects. Other COPD treatments can be used in addition to this, including inhalers or supplementary oxygen. Individuals who may have developed liver problems may need treatment for cirrhosis or even a liver transplant. So that's it for the signs and symptoms and treatments. I'll take you over to Helen now for the next discussion.
Thanks for that, Rachel. Right, so now I'm going to try tie everything together. The physiology, the genetics, the signs and symptoms, and how it relates to someone who's undergoing pulmonary rehabilitation, especially someone maybe who has alpha-1 antitrypsin deficiency. But first, let's go talk to Owen in the lab about alpha-1 antitrypsin deficiency and maybe have a look at some lung function tests. Right, let's go.
Okay, it's 2 standard deviations. Okay, so we accept that. Accept. Okay, it's all ready to go. All right.
So, yeah, we have very high rates of alpha-1 antitrypsin deficiency in Ireland. So
But it's rarely diagnosed.
it can be classed so it's often thought of as a rare disease, and we are actually covered under the authorities responsible for rare diseases in Ireland. But it's probably not a rare disease, it's more likely described as an underdiagnosed or rarely diagnosed disease.
Yeah.
The rates are 125, 125 people would have deficient allele. So it's comparable in rates to cystic fibrosis. And the interesting thing about alpha-1 antitrypsin deficiency versus cystic fibrosis, in the case of alpha-1 antitrypsin deficiency, if you've got one bad allele, you do have reduced levels of circulating alpha-1 antitrypsin. If you reduce levels of circulating alpha-1 antitrypsin, then the lungs are potentially subject to more proteolytic attack.
At what stage does someone, do you go recruit like COPD patients from?
So we recruit people from the dedicated National Centre of Excellence in Dublin, it's the
Yeah.
One Foundation approach. Okay, so it's a dedicated clinic, a weekly clinic, and a research institute dedicated to patients with alpha-1 antitrypsin deficiency.
Yeah.
Right, we're doing this spirometry test, yeah?
Yeah.
Right. So you've done one of these before, Helen?
Yep.
So, stick this clip on your nose. Feet flat on the ground, sit on the edge of the chair. I'm going to face it come forward a bit, so you want your diaphragm open, that belt isn't really tight or anything like that. Okay, so grip with your teeth, good tight seal, all your air needs to go through that, okay? I'm going to start off with a few quiet breaths, okay? Then I'm going to take a big deep breath in, all the way to the top, so really fill your lungs up, and when you get to the very top, I want you to blast out. Okay, you're blasting from down here. Keep squeezing, for another 6 or 7 seconds, okay? And then another big breath in, and then okay, you do it here. Okay, nice and relaxed. So relaxed breathing to start with. So relaxed out, relaxed in, and relaxed out. And relaxed in. Relaxed out. At the end of this one, big one in, all the way to the top. And blast! That's it. Keep long, 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 keep long. Big breath in. And away. Excellent. Perfect.
So for individuals with COPDs, they have increased cytokine levels in their body already due to the inflammation. Obviously exercise adds inflammation to that, so overall is there a beneficial effect to exercise, or can it cause more inflammation?
Yes. Now, you'll often see, so that's an ongoing debate within within the COPD literature. Where is the inflammation coming from? So your classic COPD, your NM patient, you know what I mean when I say NM patient?
Yeah.
Alpha-1 antitrypsin. The N is a normal alpha-1 antitrypsin gene, right? NM, 2 normal alpha-1 antitrypsin genes, normal alpha-1 antitrypsin levels, okay? Your normal NM patient who suffers from COPD, from what we have found and from the literature that's out there, they're older, suffer from more comorbidities than your average ZZ patient, and are more evidence of they're basically sicker than your ZZ patient, right? It's more stuff wrong, okay? And one of the consequences is this increased levels of systemic inflammation, okay? That's people have known that for years. The question is though, whether that systemic inflammation, whether that's spillover from the lungs, or whether it's some other problem that's then impacting on the inflammatory levels within the lungs. Okay, that's a question. But that's your regular COPD patient. Alpha-1 antitrypsin then patient, broadly similar pattern, but because alpha-1 antitrypsin has an anti-inflammatory property, okay, then they should potentially have more elevated levels of systemic inflammatory markers, and that tends to be the case as well. Exercise has a short-term inflammatory effect. Yeah, okay, but is that always a bad thing? Not necessarily, okay? Inflammation is part of the adaptive process. If you think of, just in very simple terms, what happens to a muscle when it adapts, okay? When you do resistance exercise, you damage muscle. One of the processes that has to happen is localized inflammation. The muscle has to be cleared out. So inflammation is a positive thing. a lot of the time. It's when inflammation is chronic and over a period of time it's never dampened down and the balance isn't there. That's when you run into difficulties. Okay, so the inflammatory impact of exercise, yes, it can make inflammation work in COPD patients, but the overall impact of exercise is positive. And when it comes to exercise training with COPD patients, basically what you're doing is you're trying to, basically in COPD patients, their lung function is way down, right? Okay, in general, it's only in really elite athletes at a really high intensity of exercise do their lungs start to limit their exercise capacity. In general, your lungs don't limit your exercise capacity, it's other stuff. Patients with lung disease, their lungs are limited to capacity to exercise, so they can't exhaust the other systems, right? So what exercise training for pulmonary patients is doing is training those other systems. You're never going to increase the lungs, you're not going to increase the capacity of your lungs to exchange gases, really. Okay, so you have to train all the other systems to effectively do more with less. Okay, so you basically, what I always say to COPD patients is you have to be an elite athlete. You've got to train everything else because you've got this smaller respiratory or lung capacity, or whatever way you want to think about it. You've got a smaller capacity to get air in, exchange it. You have to train everything else to become. You have to train the muscles to become more efficient. You have to train your cardiovascular system. You train all these things. You've got to do less with more.
Okay. Thanks very much for that, Owen. Right, lads, we've been doing a little bit of research. Now, we all know the benefits. Now, we all know the importance of physical activity and the benefits of exercise, but with the signs and symptoms of COPD, you might not want to exercise. Your fitness decreases, you lose strength. It's like a vicious circle. So this is where a pulmonary rehabilitation program comes in. COPD patients with or without alpha-1 antitrypsin deficiency will benefit from a pulmonary rehabilitation program like Breathe Smart that was run here in DCU by MedX. You cannot cure your disease, but you can improve breathing and lessen your breathing problems somewhat. A pulmonary rehabilitation program will teach you self-care techniques. It'll teach you the importance of exercise, it'll give you breathing retraining, breathing techniques. It'll teach you the importance of diet, nutrition and weight management, and it'll help you understand oxygen therapy if you're on it. Though lung function might limit your effort, you are improving strength and cardiovascular fitness. Pulmonary rehab allows you to make most of the limited lung function you have, increase your ability to exercise, improve your daily living and quality of life. Pulmonary rehab is tailored to every individual's needs. You might have someone on oxygen therapy or an individual with alpha-1 antitrypsin deficiency with weekly intravenous alpha-1 antitrypsin transfusions. And another really important aspect is peer support, the psychosocial support, the support you get from those going through something similar. There's more we don't know and a lot of aspects of the condition we don't understand. Every year more research is published showing the benefits of exercise outweigh the risks in patients with COPD. Exercise as medicine is such a new field of research and application for us as exercise physiologists to help us improve athletic and health populations. We're in a great position here in DCU with a wealth of experience and knowledge around us. Let's use it.
So it's fair to say we had a lot of fun filming this, but we also have to acknowledge that those people living with alpha-1 antitrypsin deficiency, it can be very hard for them to lead normal day-to-day lives. For so many of us here, sport plays a huge role in our daily lives. Ever since we were young lads and girls, all the friends we've made through sport, it's helped to shape us into the people we are today. For those with alpha-1 antitrypsin deficiency, however, day-to-day activities that we take for granted can seem elusive or borderline impossible. Even things like walking to college, going to the park with your friends, walking around, lying down in the grass, cheering on sport at a sporting event. When we go out for a few pucks or kicks of a ball in the park, we don't think about those who physically aren't able to do what we're doing. Something so simple as kicking a ball or running to get the ball can seem so impossible to some people that just cannot, because of a degenerative disease, capably do it. So, lads and ladies and gentlemen, boys and girls, if there's one thing that you can take from this video, is that the next time you're out kicking a ball or going training or going for a swim, just remember that somebody out there, for some reason or another, can't do what you're doing but really wants to. So just have a reminder in the back of your head that when you go out and you have your sporting activities and you're enjoying all the good moments that it brings, just remember that somebody else can't do it and wishes they can. Just have a little reminder in the back of your head that you're very fortunate and lucky. So make use of them lungs, guys. You said fucking video.
Yeah, I'm waiting for you to turn around.
You never said action, sir. What was I supposed to do?
Cheers for the.
I look the part anyway, don't I? Best of luck, Lloyd. Oh, shoot me.
No, the
You were asking me about exercise.
Yeah.
Right, so.
Thanks for that, Owen. Now, what does the research say?
The laptop already went. You put the chair there so the laptop doesn't go. Because I feel like Rachel's going to come out like that.
A pulmonary rehabilitation.
To complications such as. Okay.
Tiger Woods 3 under. Shit, I should have bet on. Fuck. That's nice. Oh, yes, good boy, good boy. Genetics an actual thing. Imagine like proper like actor, like they actually have some balls.